I'm hoping you'll take a journey with me and we'll take a step a little bit more macro level at looking at some clinical data. And I got to be honest with you in terms of the basic science data, maybe catching up with the clinical outcomes data, but in this fascinating topic, and propose that perhaps we've been working with the potentially original biological therapy for cardiovascular disease all along, and show you the data in support of influenza vaccine for secondary prevention of heart failure, cardiac events, and a clinical trial that we're running leading out of Toronto that is being done in North America. Let's see if this works okay here. And just in full disclosure, these are my disclosures and relationships with commercial interests. The most relevant one being that we'll be discussing off-label investigational use of flu vaccines for cardiac protection, and that the flu vaccines are being provided in the clinical trial by Sanofi Pasteur. So the goals of the talk are to review the burden of cardiovascular complications associated with flu and other respiratory tract illnesses, examine the data in support of influenza infection as a systemic inflammatory disease, evaluate the effectiveness of, till now, the data that's accrued for flu vaccination in the prevention of flu, but also importantly of consequences of flu and other related illnesses, particularly cardiovascular complications, and then to present to you the rationale and design of our NHLBI-funded trial comparing two flu vaccine strategies for secondary prevention in cardiac patients with recent heart attacks or congestive heart failure. So just to take a step back, so people have been thinking about this relationship between respiratory illnesses and cardiovascular outcomes for a long time. Anecdotally, we all know of our loved ones, family member, or we have patients that we treat who have come down with a major respiratory tract illness and then have been hospitalized with a major cardiac event. And you may recognize this, the name at least of Dr. Graves, of Graves' disease and others, who was at the time the chief physician at this hospital, major hospital in Dublin. He actually introduced bedside teaching into the modern era back in the turn of that century. And he was also one of the first people to investigate influenza-associated mortality. I'm not sure if he had ethics approval at the time. And what he did really was then he decided back in 1835 and 1836, he would start prospectively counting grave sites and looking at grave sites and then going into the obituaries in the newspaper and see what they died from. And then go a year later when there was an epidemic of flu and see whether or not the reported risks of cardiac illnesses and cardiac-related mortality was increased. And he found with that scientific approach, the before and after, I guess, approach, that there was a 3 times elevated risk of mortality from cardiovascular events in a flu year, a bad flu year, compared to the year before. So flash forward to a recent snapshot of the cross-sectional relationship between patients who are hospitalized with flu-related illnesses and what the risk factors for that is. And this is data from the CDC from about a year or two ago. And it's interesting how many risk factors are shared, and you could argue these are just risk factors that are prevalent in North American society, but this is what we're seeing, that are an uptick of these risk factors with regards to being hospitalized with influenza. So a pretty major complication to be actually hospitalized with an influenza-like illness. And those risk factors, including obesity, under metabolic disorders, particularly diabetes, cardiac and pulmonary diseases, are those that are commonly shared with our patients with cardiac disease. And so ever since, fast forwarding from the time of Graves to the time of the Spanish flu, and William Osler describing this, and even to the modern era since the time of the turn of the century again, that we see these cyclical spikes that I'm showing here in blue of respiratory disease outbreaks and cases in this particular era here reported in the Eastern Bloc countries and Russia. And in yellow, I'm not sure it transmits very well. In yellow, these spikes correspond to influenza outbreaks. And you can see again an ebbs and flows in a bit of a cyclical rhythm of cardiac and specifically cardiac mortality. And this data concluded after some sophisticated modeling that influenza accounted for 15 to 30% excess in cardiovascular mortality during flu epidemic years compared to off seasons and times when there wasn't a major flu outbreak. The most sophisticated observational study to do this, really, because there's really going to not be a randomized trial where we're going to randomize half the people to flu and half the people to no flu and see how they do, is the self-controlled case series analysis. And this is actually quite a sophisticated design where they'll look at people as their own controls, look back in time to see if anyone reported to their family physician any flu-like illness, and then look forward for the first, in different cycles, 28-day cycles, of how many patients ended up in a hospitalization for a heart attack or stroke, and exclude any patients with prevalent disease, eventually see whether or not that risk after every 1 month bin would come back down to the baseline risk, and then repeat this question every time, looking and biopsying the time to see whether patients were reporting flu-like illness. And so Liam Smith and colleagues presented this data in the New England now over 10 years ago, where again, the incidence of MI in first MI, 20,000 first MIs on the left or 19,000 first strokes on the right, were fivefold higher within the first 3 days of a complaint of an influenza-like illness on the left, or a threefold increased risk on the right for stroke in patients who were noting flu, and that risk would regress back to the baseline risk within about 3 months of the onset of their flu-like illness, and a real strong temporal, time-dependent relationship between the acute onset of a respiratory tract infection and the cardiac event. This has been repeated, by the way, in all over the world. It was reported in JAMA not that long ago with an American cohort. It's been reported in the Northern Hemisphere, the Southern Hemisphere, and particularly in tropical hemispheres, independent of, let's say, cold seasons, which could be a vasoconstrictor. And so there is some basic science and some translational work that has been done looking at the potential mechanisms. There's both the direct effects on the myocardium, and lots of papers reported about the influenza-associated myocarditis, focal infiltration, inflammatory cells, interstitial edema, and cardiac necrosis. And this might just be the tip of the iceberg. In the sickest of the sick, we see this in about 10% of patients, but we're not really doing endomyocardial biopsies on every patient who presents with a bad outcome from influenza, and so we may be underappreciating how much involvement there is clinically or subclinically. But most of these cases are mild and resolve spontaneously in terms of direct effects. But there's lots of systemic and inflammatory mechanisms that could be in play. So this is a busy cartoon, but I want to highlight that importantly, when you come down with anyone in this room who probably has come down at least once with a pneumonia or an influenza-like illness, you feel really bad. Your catecholamines are up, your blood pressure is down, your heart rate is up, your volume contracted, you're dehydrated, and that could really decompensate a patient who's quite fragile with cardiac disease or respiratory disease. There's probably impaired gas exchange because you're literally dealing with a respiratory tract illness, as well as there's, again, electrolyte shifts and inflammatory reactions that cause volume shifts and other things. You'll see endothelial dysfunction that's been reported in these patients. As well, you'll see, again, that procoagulant state, the sympathetic surge, and potentially taking a patient who's stable, particularly a plaque that's stable, and disrupting that plaque. And so it's been reported in the literature, again, in cohort studies, increases in myocardial infarction, increases in congestive heart failure, increases in non-ischemic myocarditis or pericarditis injuries, sometimes either directly related to the illness or as a result of some of the treatments we use, such as an antibiotic to treat a viral infection. We may see arrhythmias and proarrhythmic reactions, and as well volume overload from the treatments we give, such as fluids for these patients, that can result in direct or indirect reasons for patients presenting with heart failure and other cardiac injury. So then the hypothesis was, and when I was sitting around as a fellow doing my training in Boston, was then, could we prevent influenza by means of vaccination? Perhaps we can reduce not only influenza, but influenza-related cardiac risks. There must have been clinical trials out there in the literature that have looked at this, and so we did a systematic review of the literature, thinking that this might be an interesting question to ask within one of our large, industry-sponsored trials, if we could have this interesting public health side slant, where there are randomized trials that have reported this, potential association or reduction in risk. And so that's what we undertook in looking at major adverse cardiovascular events. And this formed the rationale for our current study, and also was fortunately published in JAMA a few years ago now, where we looked at all these small studies. There were 6 that we found, 1 that never got published, that's in our appendix. And we added up all the different data here, and so this is a traditional forest plot, and we looked in the hazard ratio or the risk ratio for a reduction in major adverse cardiovascular events within a year of being either randomized to flu vaccine, to placebo, or to just standard no vaccine, was about a 30% risk reduction, a risk ratio of 0.64 for a major adverse cardiovascular event in the next year. And on an absolute scale, that translated to about an absolute risk difference of 1.7%, or a number needed to vaccinate of 58 patients to prevent one major adverse cardiovascular event. We hypothesized that the highest risk patients may derive the most benefit, so we were able to reach out to the authors and do a patient-level analysis stratified by whether a patient was randomized who had presented in the onset of an acute coronary syndrome, or in those cardiac patients who were randomized at the time for a stable plaque and for a stable coronary disease angioplasty. And we saw that actually those highest risk patients did derive the most benefit. Not only were their absolute risk reductions higher, but the relative risk was quite robust and accentuated to about a 50% risk reduction, and that translates to an absolute risk difference of about 13%. And so that's a number needed to vaccinate of 8 patients to prevent one major adverse cardiovascular event. And this week alone, every week I'm seeing about 8 patients with a major adverse, presenting with acute coronary syndrome. And so if we, during flu vaccine season, were to vaccinate all those by this data would suggest that we could do a lot of good. 1 in 8 would be prevented a recurrent event in the next year. So problem solved. We should do this as a standard of care, but then why is it so ineffective? Well, I think that there's something to be said by the lay press, whether it's a bit of a conspiracy theory, but there is some data actually out there that the public health folks don't want you to know, that, when we talk about how good a flu vaccine is at covering you from flu, that's been tested really in healthy young adults where we get a lot of that information. And typically 80% efficacy or protection is really a really high bar, but that's really in the healthiest patients if we know there's a good vaccine, a good virus match at that time. Otherwise, it's going to be less so. And then in the patients who are actually at the highest risk, the elderly or those with comorbidities, there's actually a lesser response. And so that terminology is called immunosenescence, which is that we learn in the textbooks when we're medical students that patients with diabetes, patients with chronic kidney disease, they're relatively immune suppressed. And it turns out that there is just a lower immune response. The bone marrow just doesn't churn out as many antibodies when you're elderly or in those conditions. And so compared to the healthy young volunteers, there's even a lesser response. And so we're left with the highest risk patients being at the most at risk and the least amount of benefit from a standard flu shot. The data to support this is actually quite old now. It's from the 70s, but you can see here on the x-axis the amount of antibodies that you produced from your flu shot, and on the y-axis is how many people went on to develop an influenza infection in that year. And so on the far left are those with low antibody titers with high influenza risk, and on the far right is high antibody titers with a low influenza. And so there's clearly here a linear relationship between antibody response and flu. Is that the same case in patients with heart disease? So my colleague, Orly Vardani, who's a pharmacist at the University of Wisconsin, she's a heart failure pharmacist in the clinic, has taken on this question, and she's enrolled patients with heart failure, both ischemic and non-ischemic heart failure, and demonstrated both on the left side that just in general, the heart failure patients have a completely blunted immune response compared to healthy controls for each of the 3 strains of flu in a standard flu shot. And on the right-hand side, when she concentrated the standard flu shot and made it twice as concentrated, so a double dose compared to a standard dose, she showed that in a randomized placebo-controlled trial, she could increase the antibody response to thresholds that are considered sufficiently protected for all 3 strains of the flu shot for patients who had heart failure compared to placebo or the standard flu shot, not even placebo, in the standard flu shot where they were still insufficient antibody responses. So that was really some of the basis for potentially demonstrating this proof of concept. So our industry colleagues, flu vaccine manufacturers are always working to make a better flu shot. Ideally, we wouldn't have to do this every year, and ideally we'd have a universal flu vaccine like we have for polio, but the darn thing mutates so frequently that it hasn't been effective yet in terms of sorting out whether they can find a part of the virus that is so ubiquitous that they can get a vaccine to that part. And so every year you have to get your flu shot, and so they performed this study over 2 years, and they used a concentration of 4 times more concentrated flu shot. And they've been testing various, you've all heard, and I'm going to show you some data in a second, there's flu vaccines that have adjuvants, there's double dose, you can get a booster shot. So in this question, they did a 4 times concentrated version. They call that product fluzone high dose versus their standard dose flu shot. And they looked to see if they can confirm a reduction in flu-like illness and particularly PCR-confirmed flu. And this was published in the New England Journal about 3 years ago now. And about 32,000 patients, they showed a 24% risk reduction for an influenza-like illness on the left-hand side. And what was really provocative and was buried in their appendix is that they could actually show a reduction in pneumonia that was even more significant than that, and a reduction in any cardiorespiratory illness was borderline significant, and a trend towards all-cause hospitalization that was reduced too. These were fairly healthy patients, and so there was no real mortality signal because the event rates were also quite low. We actually took that question, that data, and looked at it in the meta-analysis because we were convinced that if we were going to do something like this, we weren't going to be able to get a placebo-controlled study performed in North America because of already the concern and the benefits, let's say the public health benefits of flu vaccines for flu. And so when we added that data to all the other small data trials that are out there, we saw a consistent benefit, just like in statins, with high-dose statins driving down LDL, as you heard earlier, or inflammation, that high-dose flu shots, or whatever way you do it, can reduce your risk by about 27%. And there's different flu shots, as I mentioned, out there. And so that high-dose flu shot, which I've just described in the top right-hand corner, is approved already for use. It's actually approved by Health Canada, approved by the FDA in routine use for patients who are over the age of 65, based on that study I showed you. And then there's the standard dose flu shot, and that covers 3 strains of flu. Then there's now a new product, quadrivalents, that are out there that cover 4 strains, 2A and 2B. We use that in children. In fact, my kids got that at their pediatrician this year, so I snuck in and got that one too. But that's only at the standard dose. There is no high dose version of that. So there's these 2 new vaccines out there. There's other vaccines all arguing that they're better than the standard shot, but what is the evidence? And so as I said, if our highest risk patients get the least amount of benefit, maybe we can do better. Is there any kind of, is there any trial that can support that for harder endpoints maybe than flu? So these are the guidelines, our public health agency guidelines above and the CDC, the US guidelines below. And the bottom line is that there is no preferential recommendation for any of the new types of flu shots compared to the standard flu shot for many reasons. One, because they're not necessarily related to hard outcome benefits, and these are more expensive. 2, because the supply is actually quite limited. And 3 is, again, back to they're more expensive. And so any new drug that's going to come on, yet something as ubiquitous as that everyone should be getting a flu shot, really public health agencies, our provinces, our governments are really looking for stronger evidence, and so are health insurers. So we shopped this trial around for a while, and we were very fortunate to get funded by the NHLBI to do this trial. We call it INVESTED, flu vaccine to effectively stop cardiothoracic events and decompensated heart failure. And it's a collaboration between us here at the University of Toronto, our colleagues and one of my mentors at Harvard Medical School and Brigham and Women's Hospital, Scott Solomon, and I mentioned Orly Vardeni and the stats group at the University of Wisconsin. And this is our large, simple, pragmatic trial. We're looking at patients who've had a heart attack or a heart failure hospitalization with one additional clinical risk factor. Those risk factors in the top right-hand corner are not only risk factors for getting cardiac events, but they're also risk factors for that immunosenescence and benefit from a higher dose flu shot. And on the left-hand side, we're giving them in a double-blinded double-blinded masked way, high-dose trivalent flu shot on the left and the standard dose quadrivalent flu shot on the right. Otherwise, background medical therapy is optimized, following them up a few times a year and coming back every year to get revaccinated to their assigned therapy for the primary endpoint of death or cardiopulmonary hospitalization. We're targeting 9,000 patients. We just wrapped up our Vanguard season, and we're starting our first full-time season this year. And we're going to have a representative cohort across North America. These are little dots that represent all the work that my team and others have done here to look at about 200 clinical sites across North America to really do this properly and to have a representative sample of patients. We have very few exclusion criteria. We're looking at those who had an MI in the last year or heart failure in the last 2 years and those additional risk factors. And we're looking, as I said, at death or cardiopulmonary hospitalization and many other clinical relevant endpoints in our patients, cardiovascular dedicated endpoints and respiratory dedicated endpoints. We did pretty well in our Vanguard year. We've already recruited 500 patients almost, and we're really rolling this out, and hopefully folks like yourselves will hopefully be interested in participating at your local center, and we should be able to report events out in about 3 years. It sounds like at the same time as some of the trials that Dr. Verma had reported. This is our study portal in case you want to learn more about our website. And that, in summary, was a little bit, I'm cognizant of the time, a little bit about the background work in terms of the cardiovascular relationship and maybe the systemic inflammatory relationship with flu and flu-like illnesses with cardiac outcomes. And hopefully our trial will be able to inform a health policy in terms of a better flu shot to protect our patients. Thank you for your attention.